Good afternoon. Our lecture for this afternoon will be on gestational trophoblastic disease. Gestational trophoblastic disease is a spectrum that encompasses benign and malignant diseases. Benign conditions would be Hydatidiform Mole, either complete or partial, placental site nodule, and placental implantation site. While malignant conditions are GTNs, invasive mole choriocarcinoma, placental site trophoblastic tumor, and epithelioid trophoblastic tumor. So the definition of hydatidiform mole is a general term that includes two distinct entities, either complete and partial HO. Features common to both forms include a hydropic state of some or all villi and trophoblastic proliferation. The two forms, however, differ on the basis of chromosomal pattern, gross and microscopic histopathology, and clinical course. Your pathophysiology can explain the difference in clinical course, histopathology, and prognosis. So question number 1, what is the most common karyotype of a complete hydatidiform mole? So for your pathophysiology of your complete hydatidiform mole, the most common is your 46XX and compared to your 46XY. While your partial hydatidiform mole would be your 69XXX, XXY, and XYY. So if you answered letter A, your answer is correct. Risk factors would be the following: maternal age, paternal age, previous molar pregnancy, diet, oral contraceptive use, and race. So a 27-year-old, gravida 1, para 0, 8 weeks amenorrhea, consults for vaginal spotting. Pregnancy test is positive. Examination revealed a boggy corpus enlarged to 16 weeks with no fetal heart tones. Cervix is closed. Cul-de-sac is full. What is your diagnosis? So for your diagnosis, we have to maintain a high index of suspicion and based on the patient's clinical presentation supported by typical ultrasonographic findings and an elevated HCG titer. So for your diagnosis, it usually symptoms present with vaginal bleeding, uterine size more than the age of gestation, presence of decalutein cysts, hyperemesis gravitarum, preeclampsia, hyperthyroidism, and respiratory failure. So for question number 2, if you answered hydatidiform mole, ultrasound diagnosis overall sensitivity is 50 to 86%. And factors that influence the diagnosis would be gestational age, expertise of the operator, and the type of HO. So, for complete hydatidiform mole, diagnosed in approximately 80% of cases, particularly during the second trimester when the grape-like or hydropic villus change occurs. Correlation of the ultrasonographic findings with your beta-HCG levels can further improve the recognition of a molar pregnancy prior to surgical evacuation. Measurement of a high HCG greater than 100,000 in association with vaginal bleeding and uterine enlargement is highly suggestive of complete hydatidiform mole. In contrast, partial hydatidiform mole is less commonly associated with markedly elevated values. The gold standard for diagnosis is still based on histopathologic evaluation. And your confirmatory tests, your cytogenetic examinations are recommended when the diagnosis of hydatidiform is in doubt. Immunostaining may be performed in cases where the histologic diagnosis is in doubt, finding your P57 KIP 2. Management would be complete and partial moles, differ histopathologically, cytogenetically, and in clinical behavior. However, management is similar for both types of hydatidiform mole. So we have our baseline laboratory examinations. We have our complete blood count, blood typing, PU and CREA, your liver enzymes, quantitative beta HCG, a urinalysis, and chest X-ray. We also test for serum electrolytes, your 12-lead ECG, APG, PT-PTT, free T4, and TSH to look for complications of H-mole, such as preeclampsia and your thyroid. Management would be to evacuate molar products. That would be your definitive therapy. To confirm pathologic diagnosis to make sure it doesn't progress to GDN, to relieve symptoms, and to prevent complications. So a 27-year-old primigravid, 8 weeks age of gestation, consulted due to vaginal spotting. An examination revealed a bulgy corpus enlarged to 16 weeks with no fetal heart tones. Cervix is closed, ultrasound showed a snowstorm pattern, and beta HCG was 164,000. What is the best mode of molar evacuation for her? So let us see how H-mole is treated. Suction curettage is the preferred method regardless of the patient's age and uterine size. Hysterectomy is an option for patients with completed family size, for patients with life-threatening hemorrhage, decreases the risk for local invasion, and does not eliminate the need for post-evacuation monitoring. Management of hysterotomy would predispose to more bleeding, would require subsequent operative deliveries, and would bring about a higher risk of post-molar GTM. While medical induction would also have bleeding, may have incomplete evacuation, and also have a higher risk of post-molar GTN. So if you answered suction curettage, you're correct. General guidelines of management would be cervical ripening should be done only through mechanical means. Decolletage cysts are left alone during laparotomy. Patients who are Rh negative should receive Rh immune globulin at the time of evacuation because the Rhd factor is also expressed on the trophoblast. All tissues obtained during molar evacuation should be submitted for histologic evaluation. Routine repeat curettage after diagnosis of a molar pregnancy is not warranted. So for prognosis, risk of malignant degeneration of a complete mole is 15 to 25%. Partial mole is 0.5 to 4%. That is why risk is high, especially among those with signs and symptoms of marked trophoblastic proliferation. That is why prophylaxis is needed. Chemoprophylaxis, methotrexate is the drug of choice and may be useful in situations where high risk for post-molar GTD and post-evacuation surveillance is doubtful. Remember, your medical induction does not remove the need for post-evacuation surveillance, neither will your chemoprophylaxis remove the need for post-evacuation surveillance. Indications for chemoprophylaxis are as follows. Age greater than or equal to 35 years old, G4 or more, uterine size greater than or equal to 6 weeks larger than AOG, decolletage cyst of more than 6 centimeters, any presence of medical complications, recurrent mole, a serum beta HCG of more than 100,000, and poor follow-up. So follow-up schedule after mole evacuation, all patients must have serial beta HCG monitoring to detect malignant degeneration. So for molar evacuation, we test the serum beta HCG after a week, then every 2 weeks until 3 normal titers, then every month for 6 months, then every other month to complete 12 months. For future pregnancies, the risk of another mole is 1 to 2% after complete H mole and 15 to 20% after 2 hydatidiform moles. The risk for stillbirth, prematurity, abortion, and congenital malformation is similar to that of the general population. So advice for future pregnancies, an early ultrasound should be performed. Beta HCG should be monitored at 6 weeks postpartum, and placenta should be submitted for histopathologic examination regardless of outcome. So referral to a trophoblastic specialist would be the following: high levels of beta HCG more than 4 weeks post-evacuation, either in your serum level or your urine level, a rise in beta HCG of 10% or greater, that is 2 consecutive weekly determinations, and plateauing beta HCG values or a less than 10% decline or rise at any time after evacuation with a minimum of 3 consecutive weekly determinations. A clinical or histologic evidence of metastasis at any site, and persistently elevated beta HCG titer at 14 weeks post-evacuation. Elevation of a previously normal beta HCG titer after evacuation, provided the diagnosis of pregnancy is included. For JPN, it also presents with vaginal bleeding, anemia, uterine enlargement, acute abdomen which may be secondary to tumor perforation, and signs and symptoms referable to the site of metastasis. So diagnosis would include initial tests of baseline serum beta HCG and your transvaginal ultrasound with Doppler studies. Your blood and urine tests are the following: CBC blood typing, your liver and renal function tests, as well as your thyroid and urinalysis. To work up for metastasis, you do a chest x-ray, whole abdomen CT scan or ultrasound, and a chest and brain CT scan, wherein the H mole would have a predilection to metastasize. So all patients must be staged and scored using the FIGO 2000 anatomic staging and WHO prognostic scoring system. So this is nice to know at your level. And management is histopathologic confirmation is not necessary to start treatment. Chemotherapy is the principal mode of treatment, and surgery and radiotherapy are adjuncts. The regimens for stage 1 or stage 2 or 3 that are low risk would be a single agent chemotherapy with using methotrexate or 2 consolidation therapies. For your metastatic high risk, you have your multi-agent chemotherapy, that is your EMACO, that would be your 3 consolidation therapies. Hysterectomy is an adjunctive treatment, and indications would be to remove a resistant focus, if there's uterine perforation, if there's profuse vaginal bleeding, and to reduce tumor load in a patient with completed family size. This is administered concurrent with chemotherapy and done in cases of brain and liver metastasis. Advantages would be it is tumoricidal and hemostatic and has a synergistic effect with your chemotherapy. Monitoring would be monthly for 6 months, every 2 months for 6 months, every 3 months for a year, and every 6 months thereafter. You will notice that this would be a more tedious monitoring than your H mole and partial mole monitoring. So you're advised to avoid pregnancy for 2 years and use a reliable contraception. So specific malignancies would be your PSTT or your placental site trophoblastic tumor and your epithelial trophoblastic tumor. These are almost always a cause of irregular uterine bleeding, often distant from a preceding non-molar gestation. So they rarely virilize or nephrotic syndrome. Uterus is usually symmetrically enlarged, and your serum HCG levels are only slightly elevated. On your histopathologic examination, PSTT would show implantation type intermediate trophoblast, while your ETT would show chorionic type intermediate trophoblast. So for immunostaining, PSTT would have a diffuse presence of cytokeratin and human placental lactogen with focal staining with HCG. So patients are classified using the FIGO system. Hysterectomy is the treatment of choice. Chemotherapy is given or IMACO. HCG is used to monitor the disease response to treatment, and same follow-up protocol as your choriocarcinoma and invasive mole. This ends our lecture for gynecology on HMOLE and GTN. Please subscribe to my channel for more lectures on gynecology. Thank you for listening to this lecture.